you might show up on the recording. So, hi everyone. This is our last lecture of this week 4. It is over more chapter 1. My point of this lecture is to try to really point you towards the difference in the vasculature and how that those differences affect the flow rate, the resistance to flow, the some of the parameters that go into blood pressure, and to talk a little bit about the flow equation and to talk a little bit about blood pressure. It's a lot that we're trying to get in. All right, so we're about in this middle third of the, if you look at the chapter 21 slides, we're in this middle third. So we're done looking at like vessel histology and vessel characteristics, and now we're looking at, okay, I have these vessels as independent entities. How do I then use them collectively to get my oxygen, my glucose, my amino acids, my water, my nutrients, my hormones distributed, my cytokines distributed? How do I get all of that happening? And in the systemic system, how do I get that happening to all the capillary beds, but as I'm distributing it to all the capillary beds, how do I do that where I want to send, out of 60 mils, I want to send 5 to the brain, 2 on the half, maybe 3 mils on the left side, 2 mils maybe on the right side. I want to spend, 1 mil to the right arm, 2 mils to the left arm, maybe because it's doing a lot more activity. I want to send a little bit of blood here and there to my ovaries or my testicles. I want to send a little blood to my pancreas. I need to send at rest about 25% of my blood, so about 100 mils or so, I forget what the math is, to the kidneys. I need to send, I just ate lunch or I just had a snack, so I need to send about 30 mils, maybe to the stomach, small intestines, large intestines. So you're taking that 60 mils and you're not evenly distributing it. And that's where the differences in the vessel radius, the vessel diameters are going to play a big role, because vessels that are going to be smaller in radius are only going to let a smaller amount of blood pass through, all right? And that's going to help, again, maybe offset and distribute blood to other vessels that are more open, more dilated, because the downstream tissue is demanding more oxygen, more amino acids, more fat, more glucose be delivered for them to have their metabolism take place. Okay, so that's the point of this slide. Now, one of the things that's in the last third that we'll talk about next week in our lecture is that when we flow through capillary beds, we are going to see leakage of some of the plasma. So if I have 1 mil of plasma going into a capillary bed, at the end of the capillary, I might only have 0.9 milliliters of blood leaving. And that means that the formed elements are staying, and they are then distributed in less velocity, or less fluid volume, because some of the fluid volume, some of the plasma, some of the water, some of the solutes have left and joined the extracellular solution. All right. Now, some of the solution in that extracellular environment has come back in, but the solutes that tend to come back in are the solutes that were the waste products. So things like urea, bilirubin, uric acid, ammonia, the waste products came back, and not necessarily glucose and amino acids and oxygen. Okay. The other thing that is the end of the vessel content was we learned that our veins are very compliant. Our veins have a lot more ability to accommodate blood in them and not moving necessarily. And so the veins are going to be where our 5 liters of blood, over half of it, up to 60% of your blood volume, is sitting at any given snapshot in time. So if I say freeze, and if I was to look at, okay, where right now do you have 5 liters of blood distributed? All right, 2.5 of those liters are probably going to be in the major veins. So again, for the major veins, inferior vena cava, superior vena cava, your renal artery, your hepatic portal veins, your splenic vein, your great saphenous vein, your axillary, your subclavian veins, the jugular, okay? All of those collective veins are probably containing, again, more of the blood volume than what's on the systemic arterial side, the pulmonary side, the coronary side, where we have blood also located. Okay, and so, and even in the heart. All right, and so again, the goal of the heart is out of this 2.5 to 3 liters of blood sitting in veins, I am trying to just suck into the right atria, and eventually that'll get into my right ventricle and left ventricle. I'm trying to suck in anywhere from about 60 to 70 milliliters. All right, and so if you go and you look again at a container of water, you know, that maybe has a liter or 2 liter contents, you're just trying to suck in with the use of those valves, with the use of your muscles, with the use of your pressure gradient pushing ability, maybe with compression clothing and different movement, and then your breath and your thoracic chest changes. You're trying to suck in a little bit of that volume in your veins to help get into the heart, so you have a stroke volume to push out the next go around. And remember, with when I give blood, so if I was today to say I'm going to go give a pint of blood, I don't necessarily faint and fall to the floor by giving up that blood, because most of the blood sitting in my veins, most of the blood sitting in my liver and my spleen, if I can push on it, if I can press it a little bit more, I can recover the loss of about a pint of blood pretty easily. If you tried to take a liter, I probably wouldn't recover as quickly. I would probably have to use a little bit more of osmosis to help suction in at least the fluid volume to be returned. And then it would take me a few weeks. Again, EPO would come back up, and some of those interleukins and colony stimulating factors would upregulate to try to get my red blood cell count back up to what it was before I gave the pint of blood or the liter of blood. So the point is, again, our body, because it has all this blood sitting in most of the veins, if you lose a little bit of blood, as long as it can mobilize that a little bit better with skeletal muscle contractions, the valves, and pressure changes, we can potentially handle some small amounts of blood volume loss. All right, so even though maybe you go to give blood and they show up with 10 vials, don't freak out. You probably can handle that. All right. Okay, so let's talk about some of the vascular characteristics. So if we were to draw our vascular tree out of, here is the left ventricle, all right? The left ventricle is going to push out a bolus of fluid. All right, that is going to be our stroke volume. And so the stroke volume initially is going to enter this first vessel, which is the aorta. All right, and if you look at your slides and the bigger version, you'll see that some of the characteristics of the aorta is it has a certain diameter. So you take the half of that, and that's its radius. It has a certain amount of wall thickness. It has one of them. And so when you do some calculations that you learn in math and geometry about how much then cross-sectional space am I sticking this 60 milliliter fluid of blood, you'll see that that fluid is being stuck in this amount of space. And I can't read those numbers, but it's there. All right. Then you enter those elastic and large number of muscular arteries. All right. And again, these are the arteries you're learning how to label. So the left common carotid, the right common carotid, the internal and external right and left common, carotids, the right renal artery, the left renal artery, the splenic artery, the axillary artery, the brachial artery, and that's the right and the left side, the femoral artery, the, greater mesenteric, inferior or superior mesenteric, inferior mesenteric. Those are the big major muscular and elastic arteries that I am sending now this 60 mils of stroke volume into. And so again, if I go through my table, there is a certain kind of average diameter to these vessels. Are they all exactly the same? No. So you're taking, again, all these vessels and you're giving them an average diameter or average radius. And again, we're just doing this for trying to make things easy for us. And then we say what the average wall thickness is. And again, will it be thicker in some areas more so than others? Yes, but just the average. And remember that wall thickness accounts for probably for the arteries, how much muscle cell layers you have, because the tunica intima doesn't really change in its thickness, and the tunica externa usually doesn't change very much in its thickness. So the layer that changes the most is the tunica media, which is where the majority of your smooth muscles are located. All right, and so that wall thickness getting a little smaller kind of represents that I've distributed a smaller amount of blood volume, so I don't need as big a tube, and the muscle layers are a little bit smaller in width, because I might not need as much muscle strength to, counterbalance the forces that the little each individual vessel needs to push against the fluid that flows inside of it. All right, and so you'll see that my cross-sectional area, so the amount of space that 60 mils is now distributed across, because there's more numerous vessels with still a decent size average radius or average diameter, that I'm now distributing those that fluid volume, the same volume. So if 1 second all that 60 mils was in the aorta, this next microsecond, now all that fluid is in this next grouping of vessels. Now I have distributed it over a little bit larger amount of surface area, cross-sectional area. All right, and then we get into the next part of the tree. So we're right about here. All right, and now we're in the arterial segment. And remember, the arterials are going to be my big kind of, if you've ever played with some of those like faucet hoses or stopcocks where you try to redirect fluid or air or sand, all right, this is where your major controls are over how much blood gets into my capillary bed. And since most of my capillaries are getting just what they need to survive and not a penny more, many of these arterials, remember, are pretty clamped down to try to just let the minimum amount of blood and oxygen and fuel into the capillary bed. All right, and that means that blood is always then available to be distributed to the locations that it's more necessary to send it, because the metabolism and the oxygen demand and the fat and the glucose and the amino acid demands are increased. All right, and so the arterioles are going to be very numerous. They are going to have still an average radius. Again, they are all different. They have an average radius just for our mathematical purposes, and they are going to then have a certain amount of cross-sectional space. All right, and so if 1 second I was in the aorta, the next second I was in your multiple or your large muscular and elastic vessels, then the next second I'm at the arterial level. This is where I usually know that I am going to come into the most resistance to flow. So I am going to then basically be able to take that 60 milliliters of blood and best divvy it out. You get a penny, you get a penny, you get a nickel, you get a dime, you get a penny, you get a penny. And that way I get my money distributed to all of these capillaries to the degree that the capillaries need to meet their oxygen demands. Okay, so the arterioles are tending to be the line of the tree, the vascular tree, where I'm going to see the most resistance, the most pressure gradient change to flow, because I'm going to see that's where the most radiuses are probably really clamped down to try to, again, limit the amount of blood flow that gets into a capillary bed. All right, now when I get to my capillary bed, oh, and the other thing about the arterioles, remember, I'm down to the tunica intima, and the tunica media is what's left, and it's just a few layers of muscle cells around the tunica intima. So I shedded here, I've lost my tunica externa layer. Okay, then I get to my capillary layer, and my capillary layer is going to be the most numerous. It's down to just the tunica intima layer, and it's the most numerous amount of vessels. And so when you take, again, an average radius and times the largest number of potential vessels that I have, this is my largest surface area. So this is where I take my 60 mils, and now I distribute it out, like I kind of use the analogy of like a tennis court. I try to spread it thinly across that tennis court. And because it's spread so thinly across that tennis court, it allows the fluid to then have the slowest fluid velocity in the entire system. So I really give myself time to let the fluid leak out and exchange, and oxygen and carbon dioxide gas to diffuse in and out as well. Okay, and then as I work my way back up, remember that the vascular network isn't equal on both sides. So there is going to be a difference in the number of eventual big veins that I have that reach back into the right atria. I have 2 that push in, whereas I had 1 come out of the left ventricle. And you'll see that the width of the vessel wall never really gets all that thick in any of these vessels like it did on the other side, because the pressure gradients that I'm dealing with and the amount of force the fluid is pushing on my walls is really not that much compared to what it was on the systemic arterial side. Okay, so I kind of wanted to show you that. And then when we look at certain vascular characteristics, now it should make more sense why we see certain things happening. So one of the first ones I want to point out is this one. All right, so this is telling me, I think this is the right one. I'm like, what is that? And I can't like make my, I'm trying to make my fingers spread the screen to look at it. This is where the blood is located, okay? So again, if I take all 5 liters of my blood, what it's showing me in this is what we previously talked about, that most of my blood at any given second in time, if I freeze, is located in my veins, okay? This up here is showing me the amount of pressure that I am going to need, and I'm going to slowly lose the pressure gradient changes I'm going to need to have to be able to get fluid to move through that segment. Okay, so if this is the size of my aorta between my hands, if I want to make 60 milliliters of fluid move from my left hand to my right hand, how much force, how much pressure am I going to need to get it to, again, flick, if it was a marble, to move from here to here? All right, and so the pressure gradient change to get to that point, oh, I'm sorry, I'm looking at the wrong one. That is located here, all right, and you can see there's a little bit of a pressure gradient, a delta P, and then there's another delta P here, all right, but the greatest changes in pressure should be here in this arterial layer, all right, and so that represents, again, where I have the most probably resistance, the most radiuses constricted to prevent my fluid from easily moving into the capillary bed on the other side. All right. And then the velocity, again, my capillaries are supposed to have the lowest velocity. And so the velocity or turbulent flow, where I'm over here, and I probably have the flow that has the least amount of resistance, the least amount of friction, the least amount of drag, the least amount of damage-inducing effects on my endothelial cells is going to be in my capillary bed, versus where I have that high resistant, high friction, more turbulent flow and more potential damage to my endothelial beds is probably going to be where, again, I either have really clamped down vessels, or I have vessels that are at their limit for what the size they can give can be. And think about that atherosclerosis model, and they have no more ability to dilate or move open, and so the blood moving through it only has that amount of fluid wall space to push through, and it's going to potentially be forced through a smaller tube than it would like. And so it'll then turn into turbulent flow. Okay, now let's talk about the flow equation. All right, so flow, normally it's Q with a little dot on the top. Okay, so flow, and this could be flow of air, flow of fluid, flow of a solid. All right, flow of this molecule, of this fluid, of this air mass is going to be dependent upon having a pressure gradient. That's what the delta P means. So there is an area of high pressure that is moving to an area of low pressure. Again, go watch the weather people. They always talk about here's a low for pressure front, here's a high, and if they show you the wind is moving into that low pressure area. All right, so what you have in your body is here's an area that has lower pressure, the fluid sitting in it, versus here's an area with fluid sitting at a higher pressure, so the fluid wants to move to the area of lower pressure. Okay, so that's the delta P. And again, trying to get blood to move, and again, especially back to the heart, this valve chamber between this set of my fingers, if I can make it a little smaller by pushing on it with my muscles, if I can wear compression clothes that again push on it and it becomes smaller and the fluid inside of it gets a little bit more pressure, again, a little bit more force to it than the fluid in the chamber above it, that is how some of that fluid moves into the next chamber. And that is how the next chamber then, with more fluid in it and maybe a little compression, maybe a little muscle pump, is going to feel again a higher pressure than the fluid chamber above it. And then your meeting? Okay, you can, but we're going out to the park. Sorry, stand by. No, give me the phone. You can wait for me to finish my meeting. All right, go ask Joseph, but then we're going to the park. Okay. Fluid pressure. All right, so that's pressure gradients. So same thing with the left ventricle. If I want my blood to, again, flow into the aorta, remember the whole thing about the isovolumetric contraction is I'm creating that fluid in the ventricle to be higher pressure than what it is in the aorta. And the second I get a pressure gradient of high in the left ventricle, low in the aorta, fluid moves into the aorta. All right, now in my aorta, I'm going to have now this pressure that the fluid is exerting on the wall. That might be an average of 100 millimeters of pressure. Remember, if I push on mercury, it would rise up to 100 millimeters height in a glass tube. That pressure to get into maybe the muscular arteries, where the muscular arteries, it might be that the pressure of the fluid in there is at 85 millimeters of pressure. So 100 to 85 is going to let me move fluid into it, and to move through again some of the divisions, some of the smaller tubings, I am going to bleed and lose some of that 100 millimeter of pressure. So when I get into those muscular arteries, now I'm at 85 millimeters of pressure. And then again, remember the next tubing is the arterioles, and the arterioles, so many of them have so much, resistance, so much radius that are super small that to get through them, I might expend 50 to 55 millimeters of pressure. All right. And so getting through and getting past those and into those aortas might mean I go from 5 millimeters of pressure to now 50 mils pressure later, I'm at 35 millimeters of pressure and I'm in the beginning of the capillary. Okay. So I am now at the capillary on one side of it, the arterial end, at about 30 mils of pressure. On the other side of the capillary at the venous end, blood sitting in there is at like 17 mils of pressure. So I have a high pressure gradient to this low pressure gradient, and that's what gets my blood to move through the capillary and not stop. So having a pressure gradient at every period of the vascular network, all right, is important because that is how I keep blood flowing and not stopping and stagnant flow where it doesn't move. Okay, and remember, I start about an average millimeter of pressure. That's what some of these numbers over here are showing you, of 100 coming out the left ventricle, because systolic, when the ventricle is fully contracted, it's pushing the fluid out about 120. When the semilunar valve closes, the pressure of the blood that's entering is right there at the end of that systolic period, beginning of the diastolic of the ventricle at 80. Average is the fluid on average pushes on the aorta and the muscular or the elastic arterioles or arteries at 100 millimeters of pressure average. Remember the right atria, the pressure of fluid or blood in there, when it's empty, it's 0. And when it has a little bit of blood in it, it gets maybe to 2. So I am going to go from the left ventricle is going to push blood out with an average pressure of 100 to start, and I am going to lose that millimeter of pressure gradient and make my way all the way back to the right atria where the pressure is anywhere from 0 to 2. Okay? All right? And so that's why we need a pressure gradient. Now, the pressure gradient is not the same amount as you go through each part of the vascular tree. All right? So if I want to say part A to part B is the pressure gradient to get from the aorta into my muscular major arteries, all right? That difference in pressure gradient, again, might be 10 to 12 milliliters in pressure, because maybe again, some of the components of resistance, which are over here, all right, are how much distance do I have to travel? That's the length, okay? So the length is going to pretty much, unless we're growing children, be a stable factor. I need to travel 5 millimeters. All right. So that length that I need to travel is one component of how much of my change in pressure, my delta P, I'm going to have to figure out I need to get from the aorta into most of my muscular arteries. All right. Then I have, what is the viscosity of the blood? And remember, viscosity of the blood doesn't change on the dime, but it can change if we get some IV bags and we overhydrate, or if we dehydrate and we get our plasma to be less than normal, and our formed elements start to then be, suspended in less fluid volume. And that's the viscosity, the thickness of the blood. And again, most of the time that is not a factor that changes, but it can. All right. And then there's blah, 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 length of the vessel. Then there might be I think in this equation, there's an accounting for other factors, which could be gravity and the fluid volume flow, and some of the other factors that we're not going to talk about, but usually in physics you talk about. All right. And then the third and the main component that's going to have, again, the difference between, do I need a big pressure gradient or a small pressure gradient to get blood to move into this next part of the tube, is the radius. Okay. And because, again, the arterioles have collectively so many of them with these small radiuses, if you get a bunch of them to dilate a little bit, you will see that your resistance to flow will very at the degree to the 4th power of the radius change, will end up I said dilate. So we'll see the resistance really, decrease a significant amount, and the pressure gradient, the delta P you have to come up with, is going to shrink. Versus if your arterioles on a good portion of them constrict a little bit more tightly, then the resistance to flow, because again, looking at this equation, the radius is to the 4th power. So a small change in the radius is really amplified out if a bunch of the arterioles, increase or their constriction purpose, and our resistance is going to go up and our delta P is going to widen. All right. And so the key point I'm trying to make is, when we talk about getting blood into the system, we want blood to flow at a rate of 5 liters per minute, or a rate of 60 milliliters per beat. All right, so that stroke volume is going into the next tree of the vasculature with every beat that I have. And over the course of a minute, I hopefully have gotten through the system 5 liters of blood through. All right. And again, that resistance is going to be, I know I have some factors I am going to have no matter what, like a distance I have to cover. I know I'm going to have the viscosity of the blood at that given second. I know I'm going to have at different areas, different parts of the vasculature, more more resistance because the velocity is more turbulent, like over here, and there's more friction and more stress and more drag versus the areas where the vessels let it be more laminar flow. And then gravity does play a little bit of a role. Again, we see that especially with getting blood to the brain. So that's why usually if I don't have enough pressure to start at the left ventricle, one of the first places I'm going to notice the lack of blood getting to one of the capillary beds is my eyeballs. And I'm going to see my vision start to kind of fizzle out. And then eventually not getting blood to my eyeballs and not getting blood to my brain, my body's not going to like that and is going to try to make me pass out and go to a position where I'm flat against the ground, and the gravitational effects of getting blood to my brain is about the same as getting to my feet and my belly, okay? But normally gravity doesn't always affect every place that, and in every situation, maybe that resistance to flow is occurring, okay, but it can. So when we look at the equation of what's going to make, again, blood flow have the hardest time, require the greatest pressure gradient in the short second by second change, is going to be anything that usually influences the radius of a large number of your arterioles. And the reason why the arterioles are the big kind of stopcock region is so many of them are going to, again, have some level of constriction. And if I get a bunch of them to go a little bit more constricted, that change in the radius across so many of these arterioles, and that effect, having a to the fourth power effect, is going to very quickly make my resistance to flow go up, make my changes in pressure I require to get blood to go through that kind of paper of the system. If it's kind of like karate chop, I want to punch through the paper, well, that paper is going to turn into wood as more and more of these arterioles constrict up, and it's going to be harder to punch through as blood and get to the capillary network behind it. Okay. On the flip side, if more of the arterioles get told to dilate, my paper becomes even more flimsy and more easy to punch through, again, because the resistance that is now there at the arterioles to the fourth power amplified up has decreased so much that my pressure gradient doesn't have to be as wide. Okay. So again, we don't always hit gravity, and we don't always talk about the fluid velocity, the type. They are factors that can play. This is why when you're in an airplane or when you're doing flight maneuvering or going up into space, if we get the force of gravity because of the velocity and the direction we're traveling, the G-force goes up to 4 Gs, 5 Gs, you will see, and it's real funny if you go on the internet and look at what's called G training for fighter pilots, and they have to practice pulling 6 Gs for 30 seconds, 8 Gs for 7 seconds, 9 Gs for like 8 seconds. Their face and everything just kind of sags, because when you see the amount of pull that 8 or 7 or 6 Gs has on our bodies, just physically, it pulls down. And they do this by centripetal force because they're in a centrifuge. All right. Usually you're doing this in an airplane by pulling up and diving like a rocket would straight to the sky. All right. And that force of increased gravity makes it harder, again, because the resistance to get blood to the brain gets to be so much that the amount of pressure gradient you have to generate to get blood up there becomes so big, it's not really possible. And so the G-straining maneuver and the tools that they learn are to try to, again, keep blood moving back to the left and right atria, left ventricle, and to try to keep some blood movement while they're doing this turn. Otherwise, like if you stood up and you don't have enough blood pressure to your brain, they're going to pass out, and they're going to, hopefully let go of the controls when they pass out, and their steep climb will stop. And the threat of it is, if you don't have any controls on being handled, the quick pull up becomes a lawn dart towards the ground. And if you don't wake up very quickly, you're now in an airplane barreling towards the ground at a very high velocity, and the ground's coming up very fast. When people pass out from high G maneuvers, they have amnesia and they don't know what's going on for a few seconds. And again, a few seconds when you're in a lawn dart is not where you want to be. So resistance, again, is what we have to overcome to, again, when the left ventricle pumps out its stroke volume, it gets to all of those capillary beds, and it gets to all those capillary beds with still a little bit of pressure behind it, that the blood moves through the capillary bed into the veins. What you don't want to do is get to the capillary bed, and the capillary bed, the pressure on the arterial side of what is the fluid moving in the capillary bed and pressing against the wall is at 0 or really low, because then the fluid won't move into and through the capillary bed. It'll become stagnant. And stagnant blood will bleed off all of its nutrients to the environment, and if it's still not moving, then that area is now becoming ischemic, it's not getting oxygen, it's hypoxic, it's going to start getting crazy, because if it doesn't start to get the nutrients it needs, the blood doesn't start to flow, it's going to start to die. Okay, so that is kind of what I wanted to talk to you guys about today. When we talk about, again, keeping blood flow, I then need to overcome these sources of resistance, and I need to have a pressure gradient, all right? And our blood pressure is the average pressure that we start with. That's our mean pressure at the left ventricle, and it needs to be a high enough number that it can overcome all of the resistance that it will face as it moves from the left ventricle back to the right atria, and it can distribute that blood with velocity to flow through all the areas so it can deliver the nutrients. All right. And on average, for most people, your mean blood pressure needs to be, and I think I have that the next slide, somewhere around that 100 millimeters of mercury pressure. And you achieve that when the ventricle is fully contracted during the cardiac cycle, its ventricular systole phase. Remember, it got up to that 120 amount of push behind the fluid entering, ejecting out. And again, when people measure their blood pressure or through the machine or by the little, stethoscope and the device, that 120 is where the blood can, if I completely close down the vessel, so there's no open, when it starts to be an opening that blood can then push through, that's considered the pressure that I can start to push the walls open and start to let a little bit of blood flow. All right. And then the point at which the blood flow stops being turbulent and starts to turn into laminar flow, that's when I know I have opened the blood vessel to a large enough amount, that diastolic pressure, where again, I don't have the sound and the turbulence and the whooshing and the damage occurring to the endothelial cells that I hear with the stethoscope. Okay, and so the systolic and the diastolic pressure again represent the fluid coming at the ejection and the ejection at its highest point, and then the point which the ventricle is no longer able to keep pushing blood out, the semilunar valves close, and those vessels kind of have compensated a little bit and they push back, and that fluid continues to move, and it moves with a little bit of push against the vascular wall. The mean is the average of the systolic plus the diastolic. So if I'm 120 over 80, my mean blood pressure should be 100. My pulse pressure is going to be 120 minus 80, and that represents the range that I achieve when I have my semilunar valve open to when it closes again. And that range is, again, about 40 millimeters of pressure on average. All right. And what I really like about this slide, again, I initially start with 100, and right away, that little bit of fluid is going to move into the arch. So it moved a little bit of distance. So right away, if I'm, following the equation correctly, to move or flow that little bit of distance with the viscosity that I have of the blood, with whatever gravity, with whatever turbulent issues I have going on, I have bled a little bit of pressure off. So the line is actually dropped a little bit. And then by the time I go through, and again, the blood's beginning to be distributed a little bit, and I get that 60 mils across most of my elastic and most of my muscular arteries, my average mean pressure of the fluid pushing on the walls of most of those vessels snapshot in time is now probably down 5 to 10 millimeters of pressure because it's moved this much distance, the velocity, the gravitational effects, and the fluid velocity. All right. And then what happens when I get into the arterioles? Because the arterioles, so many of them are so constricted, to be able to push a little bit of blood into them, there is a huge drop in the pressure. Okay, so my greatest changes in mean pressure of what I start with at the start of the arterioles versus what I have at the end of the arterioles, that biggest drop in pressure from about, what is this, about 90 or 80 to about 25, all right, so that delta P, I don't do good public math, of about, let's say, 50 millimeters of pressure, that occurs because these vessels collectively offer up the most resistance. And they offer up the most resistance, so they are the target location for when I want to try to make resistance, make afterload decrease. They are going to be my target to try to get a large majority of them to dilate a small fraction. And if I can dilate and increase their radius of a large enough grouping of these guys, my resistance should come down enough, my afterload should go down enough that the amount of pressure now that I have to get through them should decrease. And if that decreases, if it was here, then think about it. If the amount of pressure I needed to get through them was this, then I wouldn't need to start up here. I could start right here and go down. All right, so that's the implication of why the arterioles and manipulating the radius there can be so impactful on afterload and on what potentially is going to be starting mean blood pressure, my blood pressure of the entire system that I need to have at the onset of the left ventricle pumping blood out, because that's where the greatest changes in pressure occur. That's where the greatest resistance is. All right. Again, I want to point out, I do not want blood to stop in the capillary. So I need the capillary to have a gradient of the blood entering it starts with a bit of pressure, and then the time it takes to travel the distance, the time it takes to overcome any gravity, any fluid velocity issues, any drag from that, any viscosity issues, and the length that it had to move, the distance it had to move, there is more bleeding of pressure. Okay, and that's the next part. We'll talk about that next week. That again is going to be another component of, I need blood to not stop in the capillaries. I need blood to flow, move through the capillaries. Okay. So hopefully this will, again, help you figure out what's going on. Again, we do take venous pressures. They're usually quite low. Remember, by the time I've gotten into most of my veins, I'm through the large majority of the vasculature. I'm through the large majority where resistance to flow has occurred. I still need enough pressure to get the distance back up to the right atria, right? And I still need enough pressure to be a little bit maybe above the right atria, and the right atria usually sits anywhere from 0 to 2 millimeters, maybe even 4 or 5 millimeters of pressure at times. Okay, so your venous pressures are usually quite low, just because, again, blood is sitting there, the vessels are more compliant, and because so much of the pressure has been bled off to get through the upper and prior regions of the vascular network. Right? So if I rearrange my flow equation, all right, I can get my equation for what is the average pressure that I need to overcome my my resistance to the body then flowing 5 liters of blood a minute. I know I'm saying that very convoluted, all right? But basically, if I rework the flow equation and I have it for pressure, like they talk about in math, I can have an equation that tells me what it takes for me to have flow to overcome the resistance, okay? And if I change out the Q in my equation for what is my body's flow of blood on average, I then put cardiac output in its place. I can then write an equation that says pressure, what starting pressure, what is the amount of pressure I need for delta P from the left ventricle to the right atria, all right? That pressure, it is going to equal to my cardiac output times all the resistance factors. Okay, and remember the resistance factors, the biggest one that has most influence to really make resistance change in large swings is the radius of the majority or a large number of my arterioles. Okay, so just like we talked a little bit earlier about cardiac output, if I want to make it go up, I can make heart rate change and nothing else, or I can make stroke volume change and nothing else. To a lesser degree, work through a few of these. But if I want my blood pressure to, again, go up, then what I need to potentially do is either make resistance go up, so the pressure that I need to overcome more resistance is going to increase, or keep the resistance the same, but try to push more cardiac output through the system than I normally do. So instead of pumping 5 liters a minute, let's pump 8 liters a minute. If everything else is holding true and I'm pumping 8 liters of blood, not 5, across the amount of resistance, my blood pressure that I'm going to need to get that 8 liters, because there's going to be more turbulence, there's going to be more friction, is going to then need to come up. Okay? And so this little flow chart, again, kind of like what we did in cardiac output, tries to walk you through some of that. All right. But the main point to take away is in the short term, the way to get my blood to change, the way to get really my cardiac output to maybe even change is on the afterload side, on the resistance markers, to make changes to the area where the resistance is the most potent, and that's in the arterioles, and to make a large number of the arterioles, if I want everything to go up, to be more resistant, to make them constrict more. If I want things to, again, come down, the blood pressure, the resistance, the amount of delta P I need, I want to make more of those arterioles dilate. Okay, and that's going to influence that. Now, long term, all right, long-term changes to blood pressure are going to be more on the cardiac output side, because it's thinking about, well, can I have more fluid volume in the system? And if I have more fluid volume in the system, think of it as if I have a series of pipes, and normally I have 5 liters in there, well, if I put an extra liter of fluid in there, all right, now I have more fluid in the pipeline, and more fluid in the pipeline means the pipes are being exerted by more fluid pushing on them. All right. So when we usually talk about blood pressure and how do we make changes to it for short-term purposes, we normally make short-term changes hormonally, local factor-wise, and the nervous system-wise. We try to target the radius of our arterioles. And if we can get the radius of our arterioles to, again, dilate, that's going to make our resistance go down. That's going to make short-term the blood pressure we need for the left ventricle to pump and produce for the average blood pressure at the start doesn't have to be as high. And that means that if I only get a blood pressure out of the left ventricle with 80 millimeters of average pressure, I can still get through the entire system because I've dilated and tried to reduce the resistance of the radius at the arterioles enough that 80 millimeters of pressure will get me through the system. On the flip side, if I want to or need to get my blood pressure to go up, and I do that by constricting more of the arterioles, well, now getting that average blood pressure of 100 isn't going to get blood everywhere, so I need to get the average blood pressure up to 120, 140, all right? And that now will be the starting average pressure to be able, with more resistance to overcome, to get through the entire network, all right? When we talk about long-term regulation, again, there are lots of ways to potentially mess with it. All right, this is one of the reflexes, again, for short-term regulation, the baroreceptor reflex. Okay, we'll talk about that next week. I'll go back over it. But long-term regulation, we again look at what is the fluid volume? How much fluid do I have in the system? And if I let fluid out of the system, so if normally I have 5 liters and I let fluid out, now I only have 4.5, I'm going to see that my pressure is going to go down because there's less fluid in the system to push on the walls. Conversely, and this is why a lot of times we give people IVs when they come in, if they, we want to get more fluid volume into them so we can get that blood pressure to come up. Okay, so I'm going to stop there. So I'm stopping